So let's go ahead and get started. Welcome, everybody, to this virtual discussion on advancing HIV prevention, the preventive power of PrEP. Again, in recognition of HIV/AIDS Awareness Month, we wanted to have this virtual discussion and drawing from the insights from the recent white paper from Gilead Sciences on the preventive power of PrEP and other resources. We've assembled a distinguished panel of physicians to have a rich and facilitated discussion on the practical takeaways on HIV prevention and the role that physicians can play both from the clinical perspective and a population health perspective. But before we move to that, I just want to take just a moment to cover some housekeeping. Today's discussion, as you know, is being recorded, and we will be sharing it through the ACPM communication channels. This is a non-CME discussion. We will share other opportunities that ACPM has available towards the end. The Gilead Sciences white paper I mentioned, Gilead Sciences is a member of our ACPM Prevention Alliance. You can also post your questions through the discussion feature through the Q&A feature. Post your discussion questions. Feel free to post questions throughout the discussion session. And of course, we encourage you to continue having this discussion through our ACPM online platform, ACPM Pulse. With that, it is indeed a privilege, pleasure, and an honor to turn it over to our distinguished panelists who are listed on this slide today. They'll begin with an introduction of themselves and their incredible, rich history working in HIV prevention, and then it'll continue with a facilitated discussion by Dr. Holtz. With that, Dr. Holtz, I turn it over to you.
Thanks so much, Anita, and welcome everyone to this webinar. My name is Dr. Timothy Holtz. I am an internist and preventive medicine specialist and medical epidemiologist, formerly with CDC and NIH, with a history of working on pre-exposure prophylaxis clinical trials through HPTN and MTN. I'm currently the Redstone Chair and Director of the Sumner Redstone Global Center for Prevention and Wellness. I'll turn it over to my two esteemed panelists to introduce themselves, and then I have a few introductory remarks to get us started. Dr. Elion.
Thank you, Tim. I'm Rick Elion. I'm a family physician. I've been active in HIV since the mid-1980s, and I've worked in a variety of locations. I'm a clinical professor of medicine at George Washington, and I used to work at the Department of Health in DC, helping to set up PrEP programs. And I'm research director at the Washington Health Institute, where I help support the PrEP programs there. And I'm also work with a group called Trio Health, where we do research on large cohorts of people in PrEP to understand national and regional trends. Jennell?
Thank you. So it's good to be here. So I'm Jennell Coleman, and I'm an OBGYN with subspecialty training in reproductive infectious diseases. So I've been involved with HIV prevention for over 25 years. I've lived in many cities and have always worked with cisgender women in terms of HIV prevention. Most recently, I was at Johns Hopkins for about 15 years, where I had a large NIH funded study looking at how to implement PrEP into our OBGYN clinics. I also work at the national level with ACOG, the American College of OBGYN, trying to educate our fellows on PrEP. More recently, I became the chair at Thomas Jefferson University, where I am now, and I'm also the vice president of the Women's Health Service Line Lead. So it's good to be here.
Thank you so much. And I should add, I'm also from George Washington University at the Milken Institute School of Public Health. So to get us started, just a few thoughts about this epidemic that we've been addressing in the United States now for 44 years. The U.S. has a national goal of reducing new HIV infections by 75%, a goal that will probably not be reached by the end of 2025. Although new infections have sort of plateaued and declined slightly and plateaued, the rate really has slowed. We're still seeing roughly 38,000 new infections in the United States. We know that roughly 40 to 45% of these infections are in persons who are lacking follow-up, who actually had been engaged and then were as we say, lost for follow-up or lost in the system. Those who had been tested within the last year, but really had not received any further counseling or prevention and thus a lost opportunity for pre-exposure prophylaxis. So today we are here to discuss pre-exposure prophylaxis, or PrEP, a prevention intervention that has been available now for roughly 15 years since the findings of the IPREX study in 2010. And biomedically speaking, PrEP is an extremely effective prevention intervention. It is more effective than even some vaccines that are now currently used. But there are issues and major issues with access, cost, convenience, and adherence. We know that there are roughly 1 to 1.2 million people in the US who could benefit from PrEP, but then only about a third of those actually had received a prescription in the last year. There are inequalities in who is reached and access to who's tested and who is retained in care. And there's also an extreme imbalance of prescribing. We know that a very small proportion of prescribers, roughly 3 to 4%, are providing over half of these prescriptions. So I look at the challenges here as multi-level, starting at structural levels, institutional levels, clinical levels, and individual levels. And this includes many issues that are raised by the white paper, from sexual health and behavioral risk interviews to social inequalities such as lack of access, structural racism, and even stigma both within and outside of healthcare institutions. Clinical level barriers such as awareness about PrEP and PrEP availability, as well as time and the pressure that many clinicians have in that interaction with patients. We've seen a defunding of HIV prevention and a lack of, really reduction in focus about HIV over the past year. And we also know that there are some issues around integration of this tool into other tools in the toolkit that we have, such as condoms, PEP, needle exchange, other harm reduction, and of course, HIV STI testing. So I'd like to start off with a couple of clinical questions that our providers can answer for us. How can preventive medicine physicians support the integration of PrEP into routine public health initiatives or routine clinical care, such as community screenings, HIV clinics, STI clinics, or other harm reduction programs? And either one of you can start off.
I'll take first pass at it. I think that there's two parts to answer your question. The first is that HIV prevention should be part of a conversation about sexual health. And sexual health should really be part of a primary care visit. So I think there's a need to have multiple routes that people can be exposed to it. But I first want to stress the need for just regular primary care to include this, because sexual health should be part of a routine approach, and it seldom is. When we look at the absence of sexual health histories in providers in primary care, only about 20-30% are doing that. So the first emphasis is to see it integrated into primary care. The second issue related to what you said is that anybody who comes into an STD clinic or a health clinic that's coming for sexual screening probably should have a conversation about PrEP just to understand what their exposures are. And if besides their exposures, if they have an STD, they're probably almost a candidate for PrEP right then and there. And we know that same-day PrEP is often better adhered to and has higher persistence than delaying and getting a test. Now, that depends on the site and whether you have medications available and testing, but there's not that big a harm in starting somebody on oral agents before you get the result back. Injections are a different story. But for oral agents, that is a possibility. So I think in answer to your question, that anybody with a history of an STD or coming in for STD screening is a candidate for PrEP.
Thanks, Dr. Elion. I think we've apparently lost Dr. Coleman. Technical issues. Hopefully, we're going to be able to get her back. Can you talk a little bit about sort of issues on the clinical side and why we may be seeing like low PrEP prescribing, maybe lack of support in clinical systems or institutions for provider engagement around this discussion of HIV prevention, or even prescribing PrEP. And there are also, there are time constraints in clinics, lack of awareness on the behalf of clinicians, and even some stigma. And I know maybe that is not as much an issue in the US, but I think still some say it will be. But there are many issues around the world, countries that I've worked in, around stigma of in the healthcare system against people who are at risk?
I think we should never underestimate the power of stigma in any environment. So we live in a society that often has more polarizations than we like. And I think I worked in Africa and Uganda and Kenya, and I've also worked in DC and New York City. And I'd say there's stigma in all those places in some of the communities. You might have a borough in New York like the West Village where there's not much stigma, but you go over to Queens, 30 minutes away, and there could be a lot of stigma, or Staten Island. So there's stigma and there's still persistent stigma. So the first barrier, I think, is that people are just uncomfortable talking about sex for provider. I'm talking about it from the provider's view and also from the patient's view. From the provider's view, if people are uncomfortable talking about sex, taking sexual histories, as I mentioned earlier, that's one piece that does that. The second piece is they think it's going to be a time burden and that these visits are very sensitive to time demands, and those are the structural elements. But in fact, once you get used to it, to be able to do a sexual history and to be offered PrEP might take 5 to 7 minutes of a visit. It's not that long. And so it can be integrated. So, and the third thing about lack of understanding or clinical insights, there are lots of online programs and opportunities to learn about how to do PrEP. And if somebody is interested in doing that, they can certainly, I'm sure, contact the organizers of this conference, and we can get them all the educational resources they need. From the point of view of patients, there's certainly the biggest factor we see there is a hard one to deal with, and that is risk, aversion to understanding one's own risk. And there's a great deal of people who just don't see themselves at risk. Or for a cisgender woman who might be having relations with one man, she doesn't necessarily see all the partners that man might have, be they same-sex partners or different-sex partners. And so she might not think she's at risk or doesn't want to think about what her partner could be doing, so doesn't want to consider that risk. So the issue of risk aversion that patients can do is an issue, I think, and the stigma is also a big issue. I see that Dr. Coleman is back with us, so I'll let her talk about some of the clinical barriers that she sees in Philadelphia.
Yes, sorry about that. I don't know what happened, some technical difficulties, but so I can speak from my experience and at Baltimore because I just arrived in Philadelphia for the past like 6 weeks. So I'm fairly new here. But in terms of what we saw in Baltimore, and this is also something that I've noticed when I give talks across the nation too, in terms of at least for women who are coming in for care, okay? Because I feel like that's a different population when they actually hit an OBGYN clinic. And I can say some of the barriers, I mean, they're multifactorial, and I can talk days about like some of the different interventions that we try to do to, number one, increase awareness in terms of like our staff and our faculty members and the clinicians, just to make sure that they're aware of the latest formulations of PrEP that are out there and knowing about insurance coverage and, you know, how to manage it. So that was one thing that we did, was education for our providers. But then in terms of patients coming in, there was still this whole notion, just as Dr. Elion had mentioned, just in terms of this idea behind risk and whether or not you call it risk or just like a reason to use PrEP or other terminology that people use. Because I can say for lots of our cisgender women, yes, even if they had classic sort of risk factors for just increased acquisition of, you know, HIV, there were women that are like, but that's sort of separate. That's not me. That won't happen to me. So it was trying to figure out during this short amount of time. So here's a sort of clinic level barrier, the short amount of time that we have for patients, and to pack so many things in there. It was really hard for the providers who were now educated based on sort of some of the work that I've done. But then when you have a patient and you want to even make them aware of PrEP or even recommending that they go on PrEP, there was this time constraint. So I can say for lots of the work that I did, one thing that is out there, one huge barrier is the time that it may take to talk to someone about, you know, all the things they're coming in for, but then also to bring along with that a discussion about sexual health and PrEP.
Thanks, Dr. Coleman. I'll sort of continue this discussion around this and about integrating risk assessment and sort of eligibility screening into routine care. And you were just starting to mention that, and definitely about taking sexual history. Do you know of any other tools that could facilitate this integration? Because I feel like that's the sort of bridge that sometimes prevents providers from getting to that PrEP discussion.
Right. So what we tested out, and I actually think was very successful, was the actual tool, because we found out for some providers, they were uncomfortable taking the sexual history. And again, I'm OBGYN, so even when I found that some of my own providers were uncomfortable, for one, I was shocked because I was like, wait a minute, you're OBGYN, this is what we do. But I realized people are still uncomfortable. So what we did since we had an electronic medical record that was used across all of our clinical sites, there are these questionnaires that we ask, patients to complete before their visit. And what we did was attach to one of the questionnaires just a detailed sexual history. So patients, before they arrived, they would complete the sexual history. And when they arrive for their appointments, the provider can go in and see the responses. So in that way, they didn't have to ask certain questions just de novo. They could sort of say, okay, I saw that you completed this questionnaire. Let's talk about some of the behaviors. So I think that lessened the sort of the uncomfortability that some people felt with taking a sexual history, is that now it's all documented. It's an electronic risk assessment. We also did some work with, scoring it, but it was our sort of homegrown score. But we came up with different sort of metrics to say that perhaps this person could really benefit from PrEP versus this person did not report any sexual behaviors that were traditionally considered high risk. So we did have a scoring system in there to also help providers, because a lot of them are like, well, is she really at risk? So we try to help with scoring. I can say the scoring didn't really do too much, but I think the outcome of all of that is that, yes, you can get a sexual history, especially with electronic medical records. So, and that actually helps facilitate some of the discussions.
Thank you. Let's move on to what many call the Achilles heel of PrEP, which is adherence. When I was doing studies in the 2010s, this is what we were constantly thinking about. To some extent, the introduction of injectables now has made that a little less of an issue, but still, injectables are not available everywhere, and it's not also the right method for many people. How do you counsel patients on adherence strategies, and sort of what clinical practices best support the sustained use of daily PrEP?
I'm just going to, yeah, because I don't have a complete answer for that, because I can say that I've always thought of PrEP in cisgender women as being behind other populations in terms of where we are in the whole sort of continuum, like whether or not people are aware and then they initiate PrEP and then they're sustained on it. And I still feel like for cisgender women, we are still at the awareness and initiation. So for the few patients that we had on PrEP, I can say yes, for us, there was a significant drop off after, the first, even actually after the first prescription, but also that first sort of few months. A lot of people just thought that this is for oral daily PrEP, that for cisgender women had to take it every day. Some felt as if it was just overburdensome to have to think about it every day for something that sometimes they felt like the behavior, say sexual behavior, did not happen every day, but they're taking this medicine. So we had a lot of people stop taking it because they're like, I'm no longer with that partner. I'm no longer doing this or that. So I can say from that standpoint, I think there's still a lot of work to do with oral PrEP. Now, as you mentioned, injectable PrEP, I think will help solve some of those barriers. But again, I feel like most of my work is just trying to get, people knowledgeable that PrEP exists.
I'll add to that. I think adherence is multifactorial. There's certainly patients who just don't remember to take their pills every day, and that it's hard for them to kind of adhere to that. And we know that you might not have to take them every day for them still to be relevant, but effective, but they just have trouble. There's also communities that, just as Jennell was saying, are just see their risk profile as transient and based on their behavior, their sexual behavior. So they look at that as seasons or periods of risk and they medicate accordingly. So sometimes we have to be clear that people are not taking their drugs when they're actually being exposed versus they're not taking their drugs when they're monitoring their own approaches. And that's why it's important to talk to patients about other modalities such as on-demand PrEP, which can be used with TDF for all parties and with TAF FTC for transgender for men and transgender men, right? Transgender women. And so for those two populations, on-demand PrEP can be useful in that you take one the day of and two the day of, and then one the day after, and one the day after that, so 2-1-1. And for women, it appears that you have to take more pills. I'd be curious what Jennell would say about the dosing for that, but the dosing is different for women. But this gives patients who are sort of into that seasonal kind of variation time-wise of wanting to medicate via their exposure, their sexual history, an option. The injectables are a whole different story because the injectables take away that issue of starting and stopping. But then again, they don't necessarily, because if you take an injectable and you don't come back for your second injectable, be that cabotegravir every 2 months and come back within a month after that, or lenacapavir, then you have adherence issues even with injectables because you're not committed to doing it. So these issues, though they're mitigated and somewhat attenuated with injectables, are still relevant and part of every conversation.
Mhm.
Thank you. And thank you, Dr. Elion, for mentioning on demand, or what some people call the 2-1-1 schedule. I was one of the site investigators for HBTN 067, which looked at the feasibility and sort of tolerability of a on-demand schedule. And I know that the CDC nor the US FDA recommends the 2-1-1 schedule, but I know that it is being used, particularly for MSM and transgender women. It's not applicable to cisgender women. But I was just curious, Dr. Elion, given your experience in Washington, D.C., and knowing who the high risk groups are, how common is the use of the 2-1-1 or on demand?
It's more common among the MSM community, much more common. It's relatively common in Europe and in France, where a lot of the work was done. It's not as common in the States, but the results are quite good. So I think clinicians can feel comfortable with it. And for a lot of patients, it does give them an alternative. And I think choices for this for our community is a good thing.
Right. Let's maybe delve a little bit more into the injectables, because I know the studies on cabotegravir and now lenacapavir are extremely promising, and starting to become available. How should prevention programs sort of adapt to screening practices, follow-up, and adherence? I think you were touching on this already, um, for the introduction of long-acting injectables, which, as some say, sort of solve most of our adherence issues, but as you rightly pointed out, not all of them.
Yeah, I can jump in just in terms of like my experience with the injectables. First of all, lenacapavir, like when the data came out, is so exciting because I think definitely in terms of taking away having to think about it every single day about sort of like your sexual health and your protection, I think that helps out a lot. I can say from a practical implementation standpoint, it has been very challenging, like very challenging. So for us at my prior institution for injectables, it was something that was done by our specialty pharmacy, and it was very labor intensive, I can say that. So it almost added like this secondary layer, at least in sort of the academic medical centers, in terms of this secondary layer of perhaps a barrier to having it done, because sometimes we didn't have the staffing or we didn't have it, stocked well. And then we worried about reimbursement. So I can say for us, at least for cisgender women, like the injectables, yes, we can do it, but sometimes there was a wait too. So it wasn't like something that someone could start right away. It was like, okay, let's take your information down and perhaps in a couple of weeks we'll have approval from your insurance company and then you can start it. So there's definitely some room and some opportunity to work through all of that. But I think once we can work through those sort of structural clinic level logistical issues, I think it's wonderful, especially for some of our cisgender women who are used to coming in all the time for like, their injectable contraceptive and whether or not we can sort of do those two together. So I think it will allow at least cisgender women, the number to go up in terms of who's initiating PrEP. I still do have some concerns about whether or not they'll come back in for additional injections. But I feel hopeful that that is one huge advance that will help with getting more women on PrEP. So Rick, I don't know, like your experience in DC with the injectables for PrEP.
We haven't really had enough time to build up experience with lenacapavir yet. Um, I think the experience with CAB was really a question of insurance and getting kind of authorization for it. It was a logistical financial issue rather than a clinical issue per se. But of course, that makes it a clinical issue. But Len, I don't think we're deep enough into it. I mean, one thing that we'll have to keep an eye out for is if there's any difference in reactions to the injections. There's in the clinical trials, there's some talk of a slight difference in skin reactions between Len and with cabotegravir, but at the same time, there was excellent engagement and very few dropouts in the Len trials, as well as with cabotegravir. So whatever these reactions are, they don't take away from people coming back and staying and getting the medication. But I think in the real world, it's different than in clinical trials. We'll have to see if there's any difference developing, but it's too early to say.
Mhm.
Thank you. Let's turn a little bit more towards some of the successes where in some regions and states and districts that have done a very good job of reductions and some other states who are still struggling. We know that if you look at the data, and there's some really great data about on HIV mapping of new infections in the United States across the Southern Belt. There's a lot of intersectionality among some people who are, structurally disadvantaged based on the color of their skin, based on their sexual orientation, and also use of substances. And we know these are the populations that are often the public health system and even clinicians are not as well engaged with. But Washington, D.C. has had some successes and has really greatly reduced the number of new infections. I was just curious on what you sort of programmatically, what are some of the things that you think clinicians can do and how they can engage with public health systems to make the same kind of improvements where they work that the District of Columbia has had, for example.
I think the district was fortunate to have uh, we were unfortunate to have an epidemic that, with our size, was quite high in terms of incidence and new infections. But at the same time, because we're relatively small, the resources needed to generate a proper response weren't as large as it would be in New York City or other cities. So I think the first issue was that barriers to entry were almost eliminated. People were treated irregardless of their having insurance often, and they were started on meds while insurance was adjudicated. And so the testing and provision of meds at the Department of Health was given right away. At community health centers and FQHCs, there were often very low barriers to entry. The need to make appointments for PrEP was not enforced, and so people were able to drop in and get them both day at the DC Wellness Center as well as some of the FQHCs. So I think those were some of the key areas. The second piece was a very vibrant media campaign that put banners on buses and made it normalized sexual activity and normalized the need for for HIV prevention. And more than normalized it, it made it a virtue that you're protecting people when you do it, that there's something good about doing that. So I think the wedding of both media approaches, dispelling stigma around it, and lowering the barriers for access and decreasing the barriers for access for payment for the both tests and medicines. There was a program that paid for the medications, but not for tests. And so we had to develop a mechanism to cover the laboratory work. I think the barrier, the reduction or the diminution of those barriers were the reason that we had good uptake.
Yeah, and if I might add, I think the other thing that I've found just in terms of like successful PrEP implementation was also when you think about like who's actually talking about PrEP and taking away a lot of that conversation from the clinician who may feel overburdened during a visit. So for instance, like in Baltimore, there like the health department had, the PrEP nurses who pretty much had all the protocols written up so that they could begin the conversations about PrEP, initiate PrEP, and so had all the sort of standing orders that were available. So I think that is sort of a key tool to help, facilitate PrEP discussions and initiation. Because once you kind of put everything on clinicians who are busy and doing other things, it can create this extra sort of burden on the clinicians and they may not do it. So I definitely think using these sort of alternative strategies, other folks who can follow standing orders can help out a lot.
Thank you. And Dr. Coleman, I'm intrigued the fact that you've left Baltimore and moved a short distance to Philadelphia. And just furthering this discussion about some of the structural determinants. And we know that social determinants of health play such a huge role in who is at risk. And then once people are infected, whether or not they get access and can sustain viral suppression. Any other thoughts about your experience in Baltimore about addressing those social determinants, such as insurance coverage, access, issues around employment, housing, transportation?
Right, right. That's when I feel like the public and private partnerships are really key. So I can say with my prior institution, we worked closely with the health department in terms of many different things, but PrEP was one of those. So for many reasons. So one, definitely for initiating PrEP and labs and, low cost or no cost. But I also think in terms of all the other services that were provided, especially through, public funding, federal funding, or these wraparound services, whether or not you have community health workers that are helping case managers, transportation. So in my clinical setting, we did have access to all of those things so that we would provide the transportation. If you didn't have any insurance, we could still initiate either PrEP or therapy if they needed it. So I think that's sort of the importance of all of the other, because if they don't have insurance or if your clinic is not providing these things, we do need this other source of funding to help with all these other services. Because yes, it can be very challenging to think about HIV prevention if you're hungry and you have food insecurity or, you're experiencing homelessness. Like thinking about HIV prevention may not be top of mind. So those services are definitely necessary to help in the HIV epidemic.
Yes, I know there have been some amazing housing interventions, particularly I know about those in Los Angeles and Seattle that have really had an impact on the HIV epidemic in their communities, just through the provision of even sort of the small housing interventions. I'd really like to invite everyone who's participating. It looks like we have about 22 people or so to put your questions in the Q&A. I'd love to get to any questions that those who've have tuned in to hear this really productive discussion. Please do type that in. While we wait for those questions, and I think we have about 10 minutes to go, you touched on this a little bit, Dr. Coleman, about the community-based organizations you know about. I was wondering if either of you can talk about how preventive medicine specialists can work with CBOs to optimize sort of the individual level and population level prevention.
I can address that. We did that both. I worked at Whitman Walker Health and at the DC Wellness Center at the Department of Health, and we worked extensively with CBOs and Washington Health Institute. At Washington Health Institute, we worked with a CBO where we provided sexual STI testing once a week at their site and help that be kind of an entry point for people who wanted to do that. At the Department of Health, we worked frequently with the CBOs, and we would give them kits to do testing, and we had telemedicine that people could sign up and do things quickly and easily and come in that way. Interestingly enough, telemedicine, when we first started it, wasn't used that much, but I saw recently an article published that said that telemedicine makes up close to 20% of all PrEP right now with mail order prescriptions. So that was fascinating. That was new information to me. I don't think that's the population that we care for in the Department of Health and underserved populations, but it's a large number nonetheless. And Whitman Walker had a stellar track record of working with all kinds of CBOs and bringing different kinds of entry points from those CBOs into the clinic and getting appointments for them and having outreach to and vans that went out to provide care. So those were all good kind of examples of that. In fact, they did injections in vans going to people's homes to make it more accessible to people.
That's fantastic. Yeah, use of mobile clinics for sure. And we know CBOs are often at the vanguard of those kind of interventions. I still don't see anything in the Q&A. I'm really interested to hear from those of you who are in this webinar about your experiences and any questions you have from these two experienced prevention
I'll speak to something. I think people are often concerned
Please.
about the cost of PrEP. And when you look at you being an epidemiologist, maybe you can explain this better than I, Tim, but you look at the number needed to treat, how many people you need to use that for. The numbers are I believe, lower in areas of high prevalence than would be secondary prevention for hypercholesterolemia, which is a normal thing that people do. So I think that the cost effectiveness of PrEP, and part of that's because of the costliness of lifetime of medications, is very effective. And so in terms of health systems, the benefits of PrEP make financial sense, not just sort of ethical sense.
I would agree, and it's been a while since I looked into this. I know that there were some health plans, for example, Kaiser, that were providing PrEP and have been providing PrEP for quite some time, and where others who have more of a for-profit or profit motive may not see that, unfortunately. But I think it is extremely cost-effective given the long-term cost of treatment and any complications. Anything else you'd like to add, Dr. Coleman?
I do. I do see a question in the chat too. So
Oh, good.
yeah. So the one thing that I was just going to add, and it's about pregnancy, because we didn't touch on that, and I feel like that's a topic that lots of people kind of shy away from. But when we think about eliminating perinatal HIV transmission, this is something that PrEP is a useful tool, but for some reason it's not sort of widely implemented during pregnancy times. And I just know, just through talks across the nation, when there is an incident where there is a child who is born with HIV, and we kind of do a deep dive and trying to figure out what happens, a lot of the time it is a woman who's pregnant. And again, it's like what Rick mentioned, she may not know about her partner's partner, so she could do everything right during prenatal care, everything right during breastfeeding, but it's one of those things that we don't know about the male partner or the male partner status. That's something that can impact the child. So I just wanted to put that out there, that we still have to think about eliminating perinatal HIV, because cases still do occur, and in this day and age they should not occur. So so that's one thing. But to answer the question in the chat, clinician approaching HIV prevention and testing conversations and time-limited visits. Yes, without sacrificing trust or depth. I don't have a magic answer for that, because I realize the time constraints. I mean, especially this day and age with insurance reimbursement that clinicians have when they're there. So my only suggestion for that, and this is something that we started to do, there are a couple things. For HIV testing, we try to automate that as much as possible. So meaning that when someone, since we had an electronic medical record, when someone arrived, and I was talking about the sexual history questionnaire, but as part of that, we asked them whether or not they wanted an HIV test. And if they said yes, then we had it set so that it went to actually a medical assistant who put it in the orders and the clinician signed off. So we increased testing just from that sort of flow. But the other thing in terms of PrEP, we realized that at least in our setting, that the conversation, everything may not happen during that visit. So we were suggesting that our clinicians at least talk about it and then encourage them to either come back for another conversation. We tried that out, realized that it's hard for patients to get back in with that same provider in that system. So then we developed in the EMR as well, like if a patient, you brought it up and they're like, yes, I would like to talk more about this. We had a way to send a referral. It was like sort of a warm handoff to one of our quote unquote PrEP champions. And they would reach out to the patient and do like a telehealth visit to see whether or not they were interested and talk more. So I don't think it'll all happen in that one session. Unfortunately, it has to be broken up. But I think if you bring it up, lots of patients were open to like, yes, I don't have time right now, but I'll schedule this telehealth visit later on.
Thank you. And we do have a question in the Q&A now. Have recent funding changes made a difference in how PrEP is delivered?
I think those funding changes are evolving. We have the House not being clear about how to take care of the healthcare for 25 million people. And so you got that. You've got monies for Medicaid being cut. And so I think there's going to be decreases, there's going to be price pressure. We don't know what the price pressure will mean for people who want to do, if there'll be any tiering among clinics for oral pills, which can be generic versus injections. So I think that there's no question that there's going to be impact, and it's going to be regional and state by state, and even within states, different impact. And I think that that story is still evolving. On a second level, the ability for clinicians to get information has been impacted. And you could speak to this, Tim, because some of the websites that had prevention, such as the CDC and prevention guidelines, have been taken down. You can't even get information that used to be available online. So there are still plenty of academic sites that do support those kind of things, and you can find that. But these cuts both affect access for providers as well as access for patients, and they're deleterious.
Yeah, I've noticed even looking at the CDC site on prevention with PrEP, at least one of the pages has not even been updated for nearly 2 years. So that is definitely an issue around all the most up-to-date, state-of-the-art information being available to providers and prevention specialists.
Let me say one thing so I don't just sound like Debbie Downer. Um, Colleagues in Uganda have told me that the money for some of the PEPFAR things has started to open up again, and they are able to get some of the oral medications paid for. And they have a name for when they're like stock out, I think, or something, when the shelves are bare for those medicines, and that situation has begun to improve in the last 2 months. So I don't know that that's the case necessarily in the United States, but in some of the places where PEPFAR was going, that has improved according to my sources. In
I think some
Uganda,
of the
that's all
gears,
all I can
yeah,
say.
some of the gears have started moving slowly, but the loss of the the mechanisms by which medications and funding and lab tests and all that, with the dissolution or destruction of USAID, PEPFAR really had a hard time delivering on those
Totally.
goals. But I think slowly the gears have started to move again towards the end of this year. PEPFAR, unfortunately, is still on a year by year appropriation. So we'll see what happens in 2026, but we're all hopeful. Any final thoughts? Because I think we've reached our end of our webinar time.
No, I think this is great. I think that was a wonderful discussion about current day PrEP. I am hopeful. I'm always hopeful about the future. So even though I know just in my own, like my new state, in terms of what will be possible, but we're all a bunch of bright people. I feel like we can figure some of this out and get clever with the funding situation. Yeah.
And I'll close with, think what an amazing week it would be for anybody if they got one person they talked to not get HIV and not spread HIV to perhaps one other person in their lifetime. So that within a half-hour conversation, you could change the trajectory of two people's lives for the rest of their life, potentially. So it speaks to the power of HIV prevention and to staying hopeful and persistent in our efforts.
Mm-hmm.
I agree with you there. I've always been a pragmatic optimist. There have, of course, been challenges this year, but this is something that will be, fought and won clinic by clinic, visit by visit. And I'm really happy that you're both been able to join us. Thank you for your efforts in HIV prevention. We need more of you, and in order to reach those ending the HIV epidemic goals. Thank you to ACPM for holding this webinar, and thank you all for attending.
Absolutely. Thank you very much. I'll just, I cannot even have the words to say thank you for this incredibly rich discussion between Dr. Elion, Dr. Coleman, and Dr. Holtz. I will just leave with this final couple of opportunities that we at ACPM have: an on-demand CME webinar on breaking barriers in preventive medicine, implementing comprehensive HIV care and fostering inclusive prevention strategies. And then, of course, we also have, as Dr. Coleman spoke about her experiences in Baltimore, please join us in Baltimore next year for Preventive Medicine 2026 between May 14th and 17th. Dr. Holtz talked about how housing has led to some, promising reductions in HIV prevention. And so we have a plenary session at the crossroads of housing harm reduction and HIV lessons from Baltimore. So again, we have some upcoming really on-demand and live in-person webinar opportunities for HIV prevention. And this webinar is also being recorded, and we'll continue to share this. So thank you all once again for this incredible rich conversation. And thank you to our incredible group of panelists.
Thank you all.
Thank you.
Good night.
Thank you. Bye-bye.